Welcome to the deep dive. Today, we're taking a bit of a different path from usual. We're not diving into shipwrecks this time. Instead, we're exploring the surprising world of hyperbaric oxygen therapy, HBOT, and how it's becoming increasingly relevant in modern military medicine.
That's right. We've got a really fascinating chapter to look at today. It's called HBO in Military Medicine from a 2017 publication. And it really pushes beyond just the traditional stuff, for divers. It looks at how boosting oxygen in the body could be, well, a pretty powerful tool for combat injuries, military-specific problems, a whole range of things.
Okay, right. So our mission for this depth dive, then, is to pull out the key insights from this chapter. We want to get a handle on how the military is actually thinking about HBOT, how they're using it now, and maybe uncover some of those unexpected applications, battlefield and beyond, and what's the research telling us.
Exactly. We're aiming to give you a really clear picture of this, cutting edge area, pulling out the important bits from the source, but hopefully without getting too bogged down in overly technical stuff.
Okay, so let's start broad then. HBOT and combat medicine. It seems the initial interest was really seeing it as a supportive treatment, right? Something to add on to standard surgery and trauma care in a war zone.
Yeah, and what's interesting is this isn't, a totally new concept. Our source points out advocates going back, well, several decades. Back in the 80s, the 90s, names like Kramer, Workman, Fitzpatrick, Hart, McFarlane, they were already suggesting HBOT could be valuable for service members.
And it's not just individuals. It looks like established medical groups are recognizing this too, like the Undersea and Hyperbaric Medical Society in the U.S. and the European Committee for Hyperbaric Medicine.
That's right. Both of them are constantly updating their lists of indications for HBOT. And
Yeah.
quite a few of those conditions align directly with the kind of severe injuries you see in conflict zones.
When you look at the bigger picture, that really underlines how seriously this is being taken by, mainstream medicine. But the chapter really stresses one key thing. HBOT is almost always seen as adjunctive. It works alongside standard care.
Exactly. It's not meant to replace anything. It's there to improve the chances of recovery when standard treatments, well, they might just not be enough on their own.
Makes perfect sense. You wouldn't obviously use a hyperbaric chamber instead of, say, stopping major bleeding. But a big hurdle mentioned is just getting these facilities into active combat zones. That seems like a huge logistical challenge.
Oh, absolutely. That's a really significant practical problem. How do you get this, fairly sophisticated technology where it's needed most, right in the thick of it? The chapter talks about developing more portable systems as a potential solution. Smaller units, easier to move.
Right, like those smaller single-person chambers, the monoplace ones, designed for battlefield casualties, or transportable recompression chambers for field hospitals. It even mentions the U.S. Navy looking into these portable, collapsible one-person units back in the late 90s. Emergency evacuation hyperbaric stretchers, EEHS, like pressurized bags, basically.
Yes. And what's really interesting about those EHS units is the range of uses they were thinking about. It went way beyond just decompression sickness for divers. They're considering them for smoke inhalation, carbon
Wow.
monoxide poisoning, even thermal burns, and crush injuries.
Okay, now that's getting really interesting. So the idea was to use these portable things for a much wider range of combat injuries. But surely there are big limitations with units like that.
Absolutely. I mean, if the casualty is unconscious or if their airway isn't stable, any breathing problems,
Yeah.
that's a major no-go for these portable systems. And the primary safety worry, which is pretty understandable when you're dealing with high oxygen levels, is the risk of fire.
That's a massive safety point, yeah. The chapter also mentions maybe using these stretchers not just for immediate treatment, but also for transport, like getting casualties safely by air to a bigger HBOT facility.
Which makes a lot of sense, doesn't it? A kind of tiered approach. Stabilize them first in the field with a portable unit, then get them safely to a center that can provide more comprehensive hyperbaric care.
Okay, that paints a good overall picture. So now, let's dive into some specifics. How is HBOT actually being considered for different types of combat injuries? Starting with the really severe stuff like gas gangrene, crush injuries, traumatic wounds.
Right. And this is where some of the earliest and, frankly, the most compelling evidence comes from. The chapter mentions reports going way back to the 60s and 80s showing HBOT significantly improves survival in gas gangrene from war wounds. It helps save tissue, avoid radical amputation sometimes.
Yeah.
Really big deals.
That is hugely significant, saving limbs. Massive benefit. And it sounds like it wasn't just gas gangrene, but maybe severe limb trauma generally.
Exactly. The idea is HBOT improves oxygen getting to damaged tissues where blood supply is poor. It reduces muscle death from lack of oxygen and ischemic necrosis. It helps manage compartment syndrome, that dangerous swelling, prevents infections, all critical and bad limb injuries. There was even a controlled study, mid-90s, showing it helped wound healing, reduce repeat surgeries and severe crush injuries, especially in older patients over 40.
And it touches on the nitric oxide system, a signaling pathway in the body, and how that might support HBOT's role in muscle crush injuries. So we're starting to get a sense of the biology behind it.
Yeah, the understanding of why boosting oxygen under pressure helps in these specific cases is growing. Military surgeons were apparently considering HBOT more routinely as an adjunct to surgery, trying to lower complications and mortality.
But it's not all perfectly clear-cut, is it? That review of war extremity injuries, it mentioned fewer infections with HBOT, especially in non-NATO patients, okay? But then it also noted more osteomyelitis bone infection in the HBOT group. That seems counterintuitive.
It definitely shows how complex this is. We need a really nuanced view of when and how it works best. And the chapter does note that more recent evidence reviews have called for better quality studies, more randomized controlled trials to really nail down HBOT's role in acute trauma and surgical wounds. The science is still, evolving.
Okay, let's shift gears. What about cases of extreme blood loss? That whole life without blood thing, using oxygenated fluids in a hyperbaric chamber. Sounds almost like science fiction.
It does sound pretty wild, doesn't it? But Borema's work with pigs in the 60s, it was a proof of concept. He showed that using this highly oxygenated fluid instead of blood, under pressure, he could keep them alive. That led to the first sort of empirical uses of HBOT for severe blood loss.
And now it seems more accepted. A systematic review concluded it's an established and effective option for severe anemia, especially when blood products aren't available, like in combat. That could be crucial.
Absolutely, a lifesaver potentially. The chapter even says there's a recognized physiological approach now, even a management guide for treating severely anemic patients with HBOT. It's moved beyond just anecdotes.
Let's talk about burns. Devastating injuries. The chapter mentions quite a few reports showing positive effects when HBOT is added to standard burn care.
Yeah, the potential upsides for combat burns are pretty significant. It might reduce how much surgery is needed, shorten hospital stays. There's even some evidence suggesting it could lower mortality in the really severe cases. The theory involves fighting bacteria, reducing swelling, dampening inflammation, limiting the initial burn damage, and boosting collagen for healing.
And timing seems key again. Starting HBOT soon after the injury gives the best results.
That's what the research generally points to. But it's important to say the chapter is clear that some studies haven't shown such a clear benefit, or maybe just a marginal role. So it's not a magic bullet for every burn patient. A controlled study on experimental burns did back up the positive effects, maybe by reducing swelling and keeping the tiny blood vessels working in the burn area.
So the evidence isn't universally strong, but the potential is definitely there for combat burns. Warrants more research, careful patient selection maybe.
Precisely. Now let's shift to an area that's gotten a lot of attention recently. Post-concussion syndrome, PCS, traumatic brain injuries, TBI, and PTSD.
Yeah, this is such a complex and sensitive area. The chapter notes the sad increase in these conditions among personnel returning from recent conflicts, and PCS symptoms are so varied, physical, cognitive, emotional, and often don't clearly show up on scans.
Exactly. And what's particularly interesting is the initial hope, the anecdotal evidence, suggesting HBOT might help. The thinking was maybe the extra oxygen could help repair brain tissue that's damaged and struggling for oxygen after an injury like a blast.
Right, and it mentions that Harch study from 2012, reporting significant improvements across the board, symptoms, physical exams, cognitive tests, quality of life, even those SPECT brain scans, in military folks with chronic blast-induced TBI, PCS, and PTSD. After HBOT at 1.5 atmospheres, that sounds very positive.
It does sound promising, yeah. But that's where you hit the conflicting evidence wall. A more rigorous trial, double-blind randomized, by Wolf and colleagues, same year, 2012. They used a higher pressure, 2.4 ATA. And they found, no significant effect on post-concussive symptoms after mild TBI.
So right there, different studies, different results. And it seems the bigger reviews looking at all the evidence have been more cautious about recommending HBOT routinely here.
That's right. The Cochrane Review, also in 2012, looked at several studies. They saw maybe a reduced risk of death, some improvement in initial Glasgow Coma Scale scores.
Yeah.
That's the consciousness assessment. But they concluded there wasn't enough strong evidence for good long-term outcomes. So they didn't justify routine use for TBI based on what they had then.
And it looks like a big DoD and VA collaborative study also didn't find significant effects for persistent post-concussion symptoms either.
Correct. And then there was that Miller trial in 2015. HBOT wasn't better than a sham treatment for PCS symptoms. Though, interestingly, both the HBOT and the sham groups improved compared to standard care alone, which really highlights the placebo effect possibility here. However, a meta-analysis combining studies by Wang in 2016 did suggest significant improvement in GCS scores and overall outcomes with HBOT and TBI patients.
So the takeaway seems to be maybe some utility in more severe TBI, but for PCS and related issues like PTSD, the evidence is just, well, not clear yet. Needs more solid research.
Agreed. Definitely needs more work. Okay, let's move to a very specific challenge. High-altitude cerebral edema, HACO, and high-altitude pulmonary edema, HAPO.
Right, serious emergencies for troops deployed at high altitudes. And these portable hyperbaric bags sound like a specific solution for when you just can't get someone down immediately.
Exactly. These lightweight inflatable bags basically simulate descent by increasing pressure. Buys crucial time. The chapter mentions a report where patients with HACO and HAPO saw symptoms resolve in just 4 to 6 hours using these bags.
Even the Wilderness Medical Society gives them a pretty strong recommendation, though they stress getting the person down physically is still the best treatment if possible. The bag is a bridge.
Absolutely. And the GAMO bag, a specific type, has even been used for altitude mountain sickness, AMS, the less severe form. There are protocols using slightly raised pressure, about 1.25 ATA, leveraging how oxygen constricts blood vessels to minimize AMS symptoms and rebound effects.
It's fascinating how the tech adapts to these unique, tough environments. Though that sobering case report, patient responding initially in the chamber but dying after removal, really hammers home that these are aids, not cures.
It's a critical reminder. Descent is key for serious altitude illness. These chambers are vital when that's just not an option right away.
Okay, briefly then, hearing loss and tinnitus. A huge issue for veterans, the chapter says.
A major and sadly growing problem. All the exposure to blasts, noise, autotoxic chemicals. Unfortunately, a big review of the literature up to 2007 found no strong evidence from good studies that HBOT really helped significantly with these.
That's tough news. Some earlier, maybe less rigorous studies hinted at maybe helping acute cases or a psychological element.
Possibly. But a more recent review in 2012 also concluded there's no solid evidence supporting HBOT for chronic, sudden hearing loss or tinnitus. So right now, the science doesn't really back it up for those conditions.
Lastly, before we move on from injuries, spinal cord injury, another area seeing a tragic increase in recent conflicts.
Yes, and this is where some of the preclinical work, the animal studies, are showing a bit of promise. Research suggests spinal cord injury might involve excessive nitric oxide production. And early HBT could potentially protect nerve cells, help recovery, by regulating that pathway, the inos-no pathway.
That sounds encouraging, at least in early research. Other animal studies, too, showing protective effects, may be linked to things like VEGF for blood vessels or connexin 43 for cell communication.
Yes, exactly. There's ongoing work in animal models suggesting HBOT might change the inflammatory environment after injury, maybe modulating macrophage populations in a way that encourages nerve fibers to grow back, leading to better function. Still early days, animal models, but definitely generating interest.
Okay, now the source also talks about something maybe less obvious. HBOT in military responses to natural disasters.
Yeah, this really shows the wider value of military medical capabilities. Great examples given. The Italian Navy sending a mobile chamber after that earthquake in Molise, Italy, back in 2002, specifically to treat crush syndrome, try to prevent amputations.
And Haiti in 2010, after that terrible earthquake. The hyperbaric chamber on the Italian carrier Cavour apparently saved a lot of limbs, especially in kids with badly infected crush wounds.
Absolutely. And looking back at the data from Haiti, it even suggested HBOT helped reduce pain, reduce the need for paracetamol, possibly because constricting blood vessels cuts down swelling and inflammation. It really shows how these specialized military assets can be incredibly valuable in civilian disaster relief.
Beyond therapy, the chapter also gets into the history and current use of hyperbaric environments within the military itself. diving operations.
Right, takes us back to the roots of it all. Those urinators in ancient times doing underwater work for military purposes. Fascinating.
And then World War II, the Italian Navy divers using those closed-circuit oxygen systems for stealth raids, which ironically helped us understand oxygen toxicity better, something Paul Burt had figured out theoretically way earlier.
Yeah, it's interesting how oxygen diving spread through navies, balancing that stealth and endurance against the depth limits needed for safety. Like maybe only 12 meters max for short periods in some cases.
And in peacetime, military divers do crucial defensive work, right? Research, rescue, inspecting underwater pipelines or structures, and that really dangerous job of clearing unexploded ordnance.
That ordnance disposal work needs special non-magnetic gear, specific diving techniques to avoid setting things off. Plus, dealing with controlled explosions nearby creates risks of barotrauma lung or ear injuries from pressure waves.
Really highlights the unique hazards military divers face, and the chapter zooms in on HBO within military diving medicine itself.
Right. And safety is paramount, often with a more complex command structure than civilian diving. This can mean stricter rules, more personnel involved, like maybe 3 divers for a bounce dive where civilians might use 2.
But a key advantage in the military setting is that shared language and training within a nation's forces, crucial in an emergency underwater. And recruitment is usually stricter too, given the responsibilities.
Exactly. And finally, the chapter touches on submarine medicine, specifically submarine rescue, high-stakes stuff.
Yeah, the thought of a disabled sub, terrifying. It talks about 2 main rescue methods: airborne subs, like the US and former Soviets used, and surface ships with smaller rescue subs or fixed systems like the McCann diving bell.
That's right. The technical challenge is basically reaching the escape hatch, getting a good seal of the skirt, and equalizing pressure to get the crew out.
And the big difference is depth capability. The small subs can go much deeper, 250 to 600 meters maybe, whereas the bells need divers to connect cables, limiting their depth. Plus, this transfer under pressure issue.
Right, TUP. Big issue. The pressure inside a damaged sub could be way higher than normal water coming in, emergency gas use, whatever. So the crew might be saturated at that higher pressure. They need decompression in a surface chamber after rescue. That's transfer under pressure capability. The chapter even has a table showing different navies' TUP capabilities and rescue depths.
Wow. Okay, so as we sort of surface from this deep dive, it's really clear that hyperbaric oxygen therapy is being looked at for way more than just diving sickness in the military. We've seen it considered for severe combat trauma, burns, neurological issues, high-altitude problems, even helping out in natural disasters.
And yeah, while the evidence is still, let's say, developing in some areas, especially things like PCS and TBI, the potential benefits of HBOT as a supportive therapy in these unique military situations are pretty compelling. Definitely warrants more good research.
We've also touched on those unique hyperbaric challenges and uses within military diving and submarine operations themselves. Shows how pressure is a factor in so many ways, conflict and peacetime.
So maybe here's a final thought for you, for the listener, to mull over. Given these incredibly diverse, often extreme environments military personnel operate in, how might future advances in HBOT technology and the protocols, how might they further boost resilience and ultimately survivability when facing both conflict and, well, unexpected peacetime events?